radius, supinate fully, and there's some really nice tissue. Keep them at 90 in there. Key point to friction. Much more tender than if I do normally. You feel slight nodular changes like that. So just nice, gentle, sustained.
How long do you use this for usually?
Total frictional session I normally do about 15 minutes.
Wow, okay.
Yeah, and I'll do about 2 or 3 different areas, so I'll spend plenty of time there, but I will jump around. I don't say sustained. I find if you go away from an area, friction your next area, or cross transverse friction there, I actually agree in both ways. So I do plenty there, but then plenty along the line of the tendon as well. I think just cross frictions, there's a little bit there. You can feel the difference in that texture. So I'll work across, then I'll sometimes put some oil on, and then I'll come back in, and then I'll start again. So I go 1, 2, 3, bit of loosening, have a feel, and then bang, back in. I know I've
so
got
you might not
something
use
there.
any oil at the beginning.
No,
Yeah,
tends to do it dry to start with.
Mhm.
Or I'll put oil on to start with, then I'll actually grab a piece of tissue cloth and just lock the tissue cloth on there, and then there. I get myself really comfortable, and I just relax and chat away to the patient about stuff.
Do you do this after, before periosteal, or do you kind of? Does
I
it...
don't always do them together.
No.
So, for example, I'll flip my treatments up. That I might do a really big frictional sessions. I might do a gentle needling session, and I might do a shockwave session. But I don't necessarily do all 3 together. Nearly always, I think you can get away with a shockwave through here. I wouldn't say that you have a great indication for doing the IMS line through there, for the simple reason you're actually quite soft. Extensor carpi, radialis brevis is quite good until we get up to there, and then that for me is all about soft tissue, and I love working long ways on that. And then lock across, and you can feel the fibres, you can feel the fibre change. You're ready, so
this is...
yeah, epicondyle. Just get the line. You find you have to kind of get a little bit of movement. That's just gone through nicely. So you can now either choose, if you're fenestrating, to just get a few little lines backwards and forwards. There we go, beautiful. A little bit deeper. The thumb on the needle makes a difference. Without the thumb, it's horrible because the needle flexes too much. So just stay off the puncture wound, but come in along that line. I'm hitting the bone, bit of periosteal pecking. I'm shallower, bit of periosteal pecking, bit of periosteal pecking, and out. Okay. Finger on the point. There's a little vein there. I'll deliberately try and miss that vein. So I'll come this side of it and I'll lock down, needle in, no big deal. And then through that line. And then you get a little second point there. That's the key component. If we look at angle and depth. Out. Yeah? There. And you get a real resistance, bang through. And I think it's a little bit like the tissue of a shin splints, the medial shin splint, fascial connective bone line. Yeah, and it does really well through. Yeah, and you can feel the resistance. There. And you can do them quite quickly. This one you can start angling back a little bit, come in. Didn't get it. Got it. Yeah. And I'll come up to about there. Yeah. You can get quite a nice line on the tissues through there. That's fine. That's actually fairly healthy tissue. Always needling this way when you're going to do it. Kind of brachioradialis, isn't it? So brachioradialis tendon. some people seem to get problems in there. Yours is clear. Yeah. There's a bit more there. Let's do that last one. I can't leave that. Locking in, locking down. Good. A couple of little holes, just pepper it a little bit. Good. And you know, often just finish with a really nice little bit of work once it's all clean. With the Shockwave, you can go reasonably high on the pressure. So I would say 100, 110 as a sort of set, and I go quite high on the frequency. I'll start on 8, but we will go up to probably 14, 15.
Oh, really?
Yeah. This just pre-numbs it. A lot of Shockwave is quite sore at the beginning, and it becomes more comfortable as the session goes on. So warm it up. You know, get it pre-numbed. Perfectly tolerable?
Yeah, no problem. I have to tell a needle base then.
I'm careful with the head of the radius, yeah?
All the RCD this, isn't it?
Okay, so then as it warms up, we'll come up to around 14 and get that really nice. Tend to do a lot of sweeping down, a lot of holding in, and trying to get that junction again that we were just talking about, needling through here. The patient's got a bit of thickening down on the distal tendons. The muscle belly is really quite short. When you scan, you can see that the tendon is really starting from there downwards. So it doesn't hurt to do the junction down there. It's a bit bonier, so you might adjust the pressure again a little bit.
It's not unpleasant
Nice.
at all. Yeah,
No, I think it's quite a nice treatment. But it's not nice on the elbow, epicondyle. It's also one